And as I said, we have two presenters today. And first up will be Dr. Melissa Ertl. And I will introduce her, and Justin Knox will go second, but I'll introduce him when his time comes. And we'll have a little bit of Q&A after each presentation. So Melissa Ertl is a counseling psychologist engaged in research on health disparities and health risk behaviors among marginalized groups, including Latinx immigrants, college students, and LGBTQ+ individuals. Melissa earned her PhD in counseling psychology with a certificate in health disparities in public health from University at Albany State University. And in August 2021, she's currently completing her fellowship. As I said, she's graduating from our fellowship here at Columbia and at NISP, New York State Psychiatric Institute, where she is focused on addressing health disparities related to sexual health and mental health among substance-using populations. So I will turn the floor over to you, Melissa, and we look forward to your presentation.
Great, thank you so much, Bob. Just going to share my slides now. Everybody should be able to see them. So hi, everyone. Thank you so much for being here today. I'm excited to be with you all and to share about my work. The title of my talk is The Impact of Traditional Gender Role Beliefs on Sexual Behavior Among Latina College Students. So setting the stage for this study, young adults and specifically Latina women experience disproportionate effects of negative sexual health outcomes compared to their white young adult women counterparts. So I know these statistics will be familiar to folks here, but in 2021, nearly half of the 26 million new STIs in the US were among youth and young adults ages 15 to 24. And within this young adult age group, significant disparities exist for Latina young adult women, in which they're 2 to 4 times more likely to be diagnosed with STIs and HIV, less likely to be tested for STIs and HIV, and also less likely to use condoms, birth control, and other forms of contraception consistently. And because of these wide disparities and differential rates of engagement in sexual health preventive care, understanding factors associated with risk and preventive behaviors among Latina young adults is really of critical public health importance to help alleviate these disparities and also inform the design of culturally responsive interventions for these populations. So one factor theorized to be linked with sexuality and sexual health among Latina young adult women is traditional gender role beliefs or Marianismo beliefs, which are traditional Latinx cultural beliefs about how Latina women should behave. And Marianismo beliefs have been described as a central organizing structure in Latinx culture and families. And this is consistent with gender role schema theory, which posits that women are socialized to endorse traditional gender role beliefs and adopt stereotypically gendered behaviors in everyday life. And in terms of how Marianismo beliefs are theorized to be linked with health behaviors, research has supported that whether and how individuals maintain their heritage cultural identifications, values, and beliefs may be linked with, fostering healthier behaviors, engaging in health risk behaviors, or lack of engagement and care altogether. And this sort of depends on the context under study, including the cultural factor being investigated and the outcome as well. But in terms of sexual health, scholars who focus on Marianismo beliefs have stated that the idealized Marianista Latina woman is viewed as virginally pure, abstinent from sex, non-sexual, and naive about sex. And she's someone who, protects her sexual purity and abstains from sex until marriage, really in terms of like family honor. And she also, sort of maintains harmony by not talking about controversial subjects like sex and birth control, and may exemplify subordinates in sexual decision-making in relationships. So from a theoretical and psychometric perspective, Marianismo beliefs are conceptualized as a multidimensional construct that includes 5 belief pillars. And these are represented by 5 separate subscales in the measure of Marianismo beliefs that's commonly used. The first is family pillar, which is the belief that Latina should be the main source of strength for the family. Virtuous and chaste, or the belief that Latina should be pure and should abstain from sex until marriage. Subordinate to others, the belief that Latina women should be obedient and submissive according to sort of a patriarchal paradigm. Silencing self to maintain harmony, or the belief that Latinas should keep their opinions and needs to themselves in order to minimize discord in relationships. And also spiritual pillar, the belief that Latinas should be the spiritual leaders of the family. So in support of the multidimensional nature of this construct, the 5 distinct Marianismo beliefs have been found to be differentially linked with health outcomes in previous research. And so in some cases, certain Marianismo beliefs have been found to be protective factors. And then in other cases, certain beliefs have been found to be risk factors for various outcomes. And prior studies have linked endorsement of Marianismo beliefs to mental health outcomes like depression, anger, anxiety, psychological distress, substance use, and life satisfaction, as well as other health outcomes like reduced physical activity, barriers to utilization of healthcare, and sexual risk behaviors, including condom use and sex under the influence of alcohol. However, limited quantitative research has examined Marianismo and sexual risk, and no studies to date have examined the sexual health behaviors of STI testing and HIV testing. So based on the few existing studies in this area, the family pillar and subordinate to others beliefs have been found to be risk factors for sexual risk outcomes, including, basically composite measures of condom use, number of sexual partners, and sex under the influence of alcohol and drugs. And on the other hand, the virtuous and chaste belief was found to be a protective factor. But studies haven't supported empirical links between sexual risk and the spiritual pillar and silencing self to maintain harmony beliefs, despite some theoretical support for these links existing. Extant research in this area has also demonstrated some methodological limitations that merit clarification, including using diverse measures of Marianismo and sexual risk behaviors, as well as conducting studies with heterogeneous samples of people Latino women who were both sexually active and those who weren't sexually active. And analyses of these studies have really obfuscated safer sexual behaviors versus abstinence, making it unclear if some of these protective factors may simply promote abstinence or if they promote safer sexual behaviors once sexually active. So for that reason, a question that really remained unexamined that I found really fascinating was wondering whether endorsement of any of the 5 Marianismo beliefs could be associated with both abstinence from sexual activity as well as sexual health behaviors once sexually active. I hypothesized that certain theorized protective factors that could promote abstinence would not also be associated with greater odds of past-year STI testing and HIV testing. Such that endorsement of certain Marianismo beliefs would only promote abstinence, but not safer sexual behaviors once sexually active. And really, this is a very focused study, but results aim to provide valuable information about STI and HIV testing and inform the design of culturally responsive, tailored health prevention efforts for Latina young adults, and particularly for Latina college students who are at the age of highest risk for STIs and HIV and who are embedded in university social contexts that may often include substance use and sexual risk behaviors. Research is really needed to illuminate factors implicated in preventing and addressing adverse sexual health outcomes in this population. So that laid the groundwork for the study, and now I'll walk through the objective and hypotheses, method, results, and implications. So guided by gender role schema theory and its application to traditional gender role beliefs among Latinas, the study objective was to delineate associations between the 5 Marianismo belief pillars and the following sexual health behaviors in a large national sample of Latina college student women. So looking at past year sexual activity versus abstinence, past year STI and HIV testing, and past year condom use. And based on theory and limited prior research in this area, we expected that certain Marianismo beliefs would be associated with decreased odds of sexual activity, and when sexually active, more consistent condom use. So the virtuous and chaste belief and the spiritual pillar, And other beliefs we expected to be associated with increased odds of sexual activity and less consistent condom use when sexually active. So the family pillar belief, subordinate to others belief, and silencing self to maintain harmony belief. And I also hypothesized that Marianismo beliefs that promoted abstinence instead of sexual activity may be associated with decreased odds of testing. So the virtuous and chaste belief and the spiritual pillar belief. So data were collected from September 2018 to June 2019 as a part of my dissertation study at University of Albany prior to my postdoctoral fellowship. And study measures included Marianismo beliefs, sexual activity and sexual health behaviors, and participants' demographic backgrounds, including immigration generational status, sexual orientation, age, and year in school. And we used snowball sampling to recruit a large sample of Latina college student women using incentives, recruiting them by email, social media, and with flyers posted on college campuses. And participation in this study was fully anonymous, but participants had the option to access a second separate survey where they could enter their contact information for a raffle that incentivized them to participate. And this separate survey wasn't linked to their responses from the first survey. And they could win one of 10 $20 gift cards or one Apple iPad. And for analyses, I conducted 4 logistic regressions to test associations between the 5 Marianismo beliefs and the 4 sexual health behavior outcomes under study. So the final sample was 611 Latina college students who met criteria to participate and who completed the study. And they identified as Latina cisgender women between the ages of 18 and 26 with an average age of about 21 years old. And all participants were enrolled in college full-time, and they represented approximately 30 of the 50 states. I'd like to highlight a few characteristics of the sample. So much of the research on cultural factors like Marianismo beliefs among Latina college students has primarily focused on heterosexual college students, including samples with upwards of 90 to even 95% heterosexual participants. But this study had a slightly more diverse sample with about 13% of participants identifying as bisexual and only 65% identifying as exclusively heterosexual, which is still the majority of the sample. And participants ranged from 1st to 5th years in college, with most being 4th years. Most participants were born in the United States, about 85%, and those who had families that have ever immigrated to the United States, most were 2nd generation immigrants, such that their parents were the generation to come to the United States. So now we'll get into the descriptive results of the study. So in terms of sexual health behaviors, the large majority of the sample was sexually active. Most participants had been tested for STIs in the past year, and exactly half of the sample had been tested for HIV in the last year. The majority of participants used condoms inconsistently, although it's notable that about a quarter of participants reported that they always used condoms for vaginal and anal sex in the last year. And about 7% of the sample had ever been diagnosed with an STI, and 4 participants comprising less than 1% of the sample were diagnosed with HIV. For results of the logistic regressions, so in each analysis, we controlled for the potential confounding influences of age, year in school, sexual orientation, and immigration generational status. And in the first model predicting sexual activity in the past year, endorsement of the virtuous and chaste belief was associated with decreased odds of sexual activity. So in other words, endorsement of the virtuous and chaste belief was linked with increased odds of abstinence in the past year. Conversely, the spiritual pillar belief and year in school were both associated with increased odds of sexual activity. In the second model, predicting past year STI testing, endorsement of the virtuous and chaste belief was associated with decreased odds of being tested for STIs in the past year. And on the other hand, year in school was associated with increased odds of being tested for STIs. In the third model, predicting past year HIV testing, only one predictor was significantly associated, and consistent with the previous model, we found that endorsement of the virtuous and chaste belief was associated with decreased odds of being tested for HIV in the past year. And finally, in the fourth model predicting condom use, none of the independent variables were significantly associated with the outcome of past year condom use. In terms of takeaway findings for this study, so a large majority of Latina college students are sexually active, with nearly 72% of Latina college students having sex in the last year, but rates of past year STI testing and HIV testing are lower than recommendations. These numbers are actually tend to be a little bit higher, almost 60% past year STI testing and 50% for HIV testing actually tend to be a little higher than recent national averages. So despite the literature showing that Latinas may be less likely to be tested for STIs and HIV, this study actually found pretty encouraging results about testing, but of course there's quite a bit room for improvement. And in terms of condom use, so the majority of the sample, about 76%, were not consistently using condoms. And 11% of participants reported never using condoms during vaginal and anal sex in the past year. Findings also provide insight into how certain Marianismo beliefs may promote abstinence, but not protective sexual health behaviors among those who are sexually active. So in this study, Latina young adult women who endorsed the virtuous and chaste belief to a greater extent were less likely to be sexually active, but once they were sexually active, these women may tend to be at higher risk for having an undiagnosed STI or HIV due to lack of testing compared to Latina women who endorsed the virtuous and chaste belief to a lesser extent. So these findings really suggest that the virtuous and chaste belief is a protective factor in as much as it's associated with promoting abstinence, but endorsement of the belief may actually serve as a risk factor for sexually active Latina young adults, because not being tested and not having knowledge of one's STI status or HIV serostatus can increase risk for transmission and has implications for, disclosure of status and health if left untreated. And then surprisingly, and contrary to expectations, greater endorsement of the spiritual pillar belief was associated with increased odds of being sexually active in the past year in this study. And this finding is somewhat in contrast to prior scholarship that suggested the role of spirituality and religiosity in promoting an emphasis on abstinence among Latinas. However, it's worth noting that some literature suggests that religiosity assessed by frequency of attendance and affiliation at religious services may have little impact on sexual behaviors once sexual activity has occurred. So although this finding is somewhat puzzling, the items that make up the spiritual pillar subscale tend to reflect a level of responsibility for the family's sense of spirituality. So it's possible that Latinas who endorse this belief may also feel greater agency and responsibility and demonstrated that agency in being sexually active, or maybe they were at greater likelihood of being sexually active because they were trying to become pregnant or grow their family. I have a few ideas on why this association was found, but nevertheless, because it's inconsistent with some prior research and because most studies have identified religiosity and spirituality as a predominantly protective factor in previous research, more future investigations should really seek to examine how spirituality and religiosity may influence sexual decision-making and sexual behaviors among Latinas. In terms of implications of study findings, culturally responsive prevention efforts should consider how endorsement of the virtuous and chaste belief may position women to remain naive about sex and not take responsibility over sexual decision-making. And culturally congruent and empowering approaches to prevention should really aim to take Marianismo beliefs into account and honor beliefs and desires to maintain abstinence while also educating women about the benefits of safer sexual behaviors like condom use and HIV and STI testing once sexually active. As for the spiritual pillar belief, future research should continue to explore how spirituality and religiosity may be a critical cultural factor that's relevant for tailored HIV prevention efforts with Latina young adult women. This project has several important limitations that I want to note, including that the brief study was focused and it didn't attend to other qualities and characteristics of sexual relationships that are related to sexual health behaviors. And this focus was really on individual level cultural factors and not structural and systemic factors that could play a larger role in sexual risk and prevention behaviors among Latinas. And our measure of condom use was in for the entire past year, which requires long-term recall and is also, a time frame that can be challenging in terms of assessing risk. So other time frames should also be explored. And we didn't investigate PrEP in this study, although it's a major interest of mine thinking about how gender role beliefs may influence PrEP decision-making. So future research should examine Marianismo in relation to PrEP among Latinas. And I also want to note that our sample included Latinas from a broad range of Latinx and Hispanic ethnic identities for whom group differences by ethnicity should be explored, but that weren't the focus of this particular study. And we focused on a national sample of college students, but Latinas who aren't enrolled in college have specific and unique needs that aren't captured by this kind of sample. So results can't generalize to other samples of Latina young adults who aren't enrolled in college. Thank you very much for your attendance. And I just want to say special thanks to my postdoctoral mentor, Susan Tross, as well as Susie Hoffman, Curtis Dolezal, and HIV Center manuscript writing workshop colleagues who helped to further hone and develop this project, as well as Kale Basaraba and Martina Pavlikova for their statistical expertise on helping me with some of the revision for this manuscript that's under review and revision at a journal outlet. And I think we have time for questions now too. There might be one in the chat. Let's see. From Christina, it seems like Marianismo would be a latent variable. Is there a reason why you didn't use latent modeling methods like latent class analysis or factor analysis instead of logistic regression, where the sub-constructs that are likely to be correlated are all entered into the model as manifest variables? Yeah, this is a great question. And I think more complex analyses might, reveal interesting findings about Marianismo and also might be sort of more kind of enhanced models to take a look at these findings. And I think for me, I was really interested in kind of associations between the subscales and the four sexual health behavior outcomes, and not as much in sort of advanced modeling using latent variables, but that's definitely something that we can explore, especially as we're looking to publish the findings from this study.
Thank you. Thank you, Melissa, for a great presentation. And you're already jumping into, thank you for monitoring the chat. I see that Teo has his hand raised. Teo?
Thank you, Bob. Thank you, Melissa. Interesting to see your work. And as usual, it's solid work. The majority of your participants were heterosexual. And related to that, I missed a critical word in your presentation, and it is conception or contraception. Can you say something about that? Why wasn't that in there, and how would that have affected the outcomes?
Yeah, this is a great question. I feel like for this study, I was more focused on, testing in particular, since that was something that was less examined. But I will say that there isn't a lot of research on Marianismo beliefs and contraception either. So I think that's another gap, and it just felt out of the scope of this sort of focus study. But I would be really interested to look at different types of contraception and how those are linked, or, what belief pillars may promote, engagement in using contraception or not, but especially because Marianismo beliefs have been linked with, in some cases, more healthcare utilization, and in other cases less. It would be interesting to see which factors, sort of promoted different, types of contraception, or even contraception broadly or not. But I know, especially for the family pillar belief, some prior studies have found that that's associated with increased sexual risk if it's measured by lack of condom use, simply because women may be trying to have a family. So I wouldn't be surprised if certain beliefs were linked with, less contraception simply because of like family goal intentions and that sort of thing. But that's a great area that I think should be explored.
And that what you just mentioned is probably less relevant in the population that you were studying, that they wanted to get pregnant.
Mm-hmm. And that's the interesting part about college students too. These are folks who are enrolled full time. They may or may not be trying to start a family, but on the whole, national averages, Latinas tend to give birth for the first time at a younger age than white young adult women counterparts. So, it's possible that some still, that family planning may be a goal for some participants. But I think if I could read you the study, there would be a lot of questions about quality of relationships that I'd ask about, as well as things like contraception.
Thank you.
I'm going to jump in. I actually had the kind of basically the same question that Teo asked, but I just wanted to I'm not sure if you said this in your response, but because I was surprised by the low condom use, particularly among college students. And I would think that the majority would not be desiring pregnancy, while they're in college, an assumption I'm making. So do you have any data about their use of pregnancy protection? Because I mean, you're noting the low condom use, and you're focused on STIs and HIV and those risks. But I'm wondering if they felt comfortable, less concerned about that, but because they were taking care of preventing pregnancy, if that's what they wanted to do in other ways.
Yeah, I actually didn't have any items on like long-acting contraception or birth control, unfortunately, but I think that would be an important sort of confound related to the condom use results. And I think it's perplexing that we didn't find any links with condom use since past studies. There have been, I think, 3 studies in this area that have looked at inconsistent condom use and sex under the influence and have found associations. So that was definitely surprising. And this sample had somewhat encouraging STI and HIV testing rates, but condom use was pretty low compared to some other national statistics. So I think that I also would have really wanted to investigate different timeframes of condom use, because I think past year is probably just hard for people to characterize. So I wonder if there weren't, error within that sort of estimation people were making that maybe affected reports of condom use too.
Thank you. Yeah, very thoughtful. How about if I read the next question in the Q&A from Joey Schrader? This is super interesting, Dr. Ertl. Marianismo played such an interesting role. Do you know if there is any role of family level Marianismo norms? Sorry, I'm not totally familiar when these cultural norms are endorsed by women.
Yeah, that's a great question. So the Marianismo belief scale asked women about, the extent that they believe a traditional Latina woman should behave in a certain way. And then items are framed as sort of refraining from sex until marriage. And then they're endorsed on a Likert type scale, from whether they endorse that item strongly to strongly agree to strongly disagree. And it is sort of an individual level belief. I'm not familiar with any like family level norms or scales that assess family level norms, but I think it would be really interesting to sort of do a dyadic study between, like, for instance, mothers and daughters, and examine how discrepancies in beliefs might lead, might be linked with other health outcomes. I know there's a pretty sizable literature on intergenerational conflict in families in terms of values and beliefs, and this could sort of be kind of examined within that lens. But I think especially actually something that's kind of come up on the pilot study that I'm focused on, that's specifically among Latinx adults who use substances in relation to PrEP, and sort of their attitudes and knowledge and beliefs about PrEP and interest and willingness. And what we're finding is that some of these sort of cultural factors that are coming up in the context of the family do demonstrate generational differences in the way that folks are saying, well, it used to be taboo within my family to be talking about things like condom use and PrEP, but now in my generation, we're much more open, and I have conversations with my children about sexual behavior and sexual activity. So I think that would be an important area for study, and at least in the qualitative project that I'm conducting, it's been coming up a lot. So that I would be interested in trying to design a study that could quantitatively get at these sort of cultural level norms at the family level that you're talking about, Chohi.
Thanks, Melissa. So we have two more. One, I read the next question in the chat from Dr. Heinemeier Balberg. Did the sample include any married women? And was there a difference in the sex behavior? I'm sorry, it just bounced. Difference in the sex behavior correlations between married and unmarried women?
Yeah, this is such a great question. And I actually don't have great data about relationship status. And that's something that after the fact, so this is one project of 3 main papers that came out of my dissertation study. And in hindsight, I focused a little more on the other 2. And for conducting this study, there really are so many questions about relationship status and quality of relationship, and questions about like number of main and casual sex partners that I think would be really fascinating and important to examine within the context of looking at sexual risk behaviors like condom use, and also looking at HIV and STI testing. But I unfortunately don't have data on what percentage of the sample was married and what proportion weren't. But looking back, I mean, that is a major limitation of the study, that we can't look for differences by those different categories.
Okay, we have several more questions, so I'm going to read the next one from Margaret Passion Wolf. Wonderful presentation, Melissa. I know that sexual orientation was not associated with the outcomes in your study, but do you happen to know if there has been other research focused on Latina, bisexual, and queer women and Marianismo? Or have you thought about focusing on this population in your future research? I'm curious about what you might find, given the research showing that adolescent bisexual women in general have higher rates of unwanted pregnancies and sexual risk factors. Thank you.
Yeah, this is a great question. And I would definitely be interested in focusing on this population because they're so understudied in the literature, and there's so little theorization even about how gender role beliefs can manifest across sexual orientation among Latino women. But, similar to what Margaret's noting, I think that transgressing, heteronormative expectations and also transgressing sort of gendered expectations would be really interesting to examine in relation to these sexual outcomes. So bisexual women and, lesbian and gay women too in this sample. I was encouraged by the number that participated in this study compared to previous studies, but there are very few studies that focus on these populations specifically, not including heterosexual Latino women.
Okay, next question is from Cersei. What a wonderful presentation. I was wondering if you would expect the lack of condom use to be associated at all with a desire to express trust in a relationship or something to that extent. Was unsure if you had a measure in your survey that captured relational attitudes. I know you had said you hope to eventually include a measure of relational trust. And yeah, great question, Cersei. I'm just going to add, more generally I was curious if you had anything from the women's perspective about the expectations of their partners or the desire of their partners that might be related, which is part of what Cersei's asking.
Yeah, I think this came up in the manuscript writing workshop too. But again, it sort of brings me back to a desire to conduct like a dyadic study as well on partners. Like you could do one with mothers, you could also do one with Latino women and their sexual partners. But I would be really interested in knowing that too, if, trust was sort of this main aspect that influenced, condom use, but at least in the pilot study we're conducting, that's come up a lot for PrEP. So I wouldn't be surprised if it was, also affecting women's decisions to use condoms with their partners too. And I know certain aspects of Marianismo are related with sort of subordination in relationships and kind of deferring sexual decision-making to men in a heterosexual paradigm. So I wouldn't be surprised if that was occurring. But yeah, again, I wish I had these wonderful attitudes about relationship qualities, because I think that would be extremely fascinating for a future study.
Okay, thank you. A question from an anonymous attendee. Great presentation. Snowball sampling can present sampling bias in participants, potentially selecting or sharing participants that are similar to them. Do you feel that there was any bias, or rather this recruitment method may have sampled the population of interest, i.e. Latina college women, being this the population that was selected? Yeah.
Yeah, this is a great question. And certainly snowball sampling, it's not, a random sample. We did sort of leverage connections within Latinx cultural centers on college campuses. And it took about 9 months to reach the sample of 600 Latina college students. But I do think that the survey was sort of shared among networks. So it's likely that participants were more interconnected than would be expected if it was a more methodologically rigorous way of sampling. I think to that point about sampling, we wouldn't want to generalize to all Latina college students throughout the entire US. It's just sort of a specific sample that we did use snowball sampling to recruit. And I think I sent over 400 emails to reach folks across college campuses across the country. So we definitely tried to throw a wide net, but it's not immune to those points about selection that were noted in the chat, definitely.
Great, thank you. I'll just mention that there's something now in the literature, it's not that new, but called starfish sampling, which is actually a combination of time venue-based sampling and RDS sampling. So that you depending on the population or the network, you have, there's methodologies about, doing both, which I think addresses some of what you just discussed. There's a question from Erica Golub. Thank you, Melissa. Interesting data. Wondering whether you included any of the YRBS measures. I'm not sure what that. Maybe you know what they are.
I think youth risk behavior survey.
Okay.
Yeah.
Measures on forced unwanted sex. This would add important context to the sexual behaviors and beliefs. Maybe something to think about going forward. Thanks.
Yeah, this is another great point. And IPV and sort of forced and unwanted sex is something that's often studied in relation to Marianismo. It's not something that we focused on for this study, but I think it would be really fascinating to look at that too, especially sort of in the context of preventive efforts that seek to empower and educate women about, the risks involved and sort of how to prevent risk in these contexts. I think that would be a really great area for future work. And that's definitely been explored qualitatively, and I'm not sure about quantitatively. So that may be a nice, a notable gap in the literature there.
Okay. Tanya, I can't tell if there are, there's no more questions in the Q&A. I see 2 attendees with their raised hands, but were they?
Yes, Bill and Susan Tross have questions.
Okay, I think we'll have time for those, then we'll have to end and move to the next presentation. So go ahead, Phil. Phil, you still there? Tanya, is he unmuted? Here he comes.
Thanks. Yeah, I was just waiting to get the pop-up. Great talk. Can you all hear me?
Yes.
Oh, cool. So yeah, I totally half comment, I guess. Just thinking about how this lines up with some of the early 2000s, and then actually one of my mentors, John Santelli, who's also affiliated with the center, has done a lot of work on abstinence only. There's a paper in the updated paper in the Adolescent Health from 2017. So I just was thinking about how relevant these findings are to that work, and they really seem to line up, right? Like you were sort of saying, these takeaways of spirituality, and then maybe having less knowledge about sex education. So I think your work is showing that this is this is a long-standing issue, and it's just exciting when, it's disturbing, we want to change this, but it's exciting when these results really just reinforce this message. I think that so many of us are thinking about Santelli and others' work has been going on for a long time. And even in light of, you raised in, these new dinner table conversations about PrEP and et cetera, but it seems like these are still like longstanding issues that like abstinence only creates this problem. So I just wanted to think about it like in this historical context and how you're showing that despite all these advances, this is still a challenge.
Mhm. Yeah, no, this is such a great point. And, I'm really interested in how sexual health prevention can be tailored to these sort of gendered aspects of socialization and what that could look like to sort of help empower people and women in particular to, be fully apprised of, sexual health prevention and maybe counteract some of these messages while still affirming the aspects that are culturally salient and, preventive too.
Great, thanks, Phil. And Susan Trost, this will be the last question before we move on. Go ahead, Susan.
Melissa, this is really just such a great study and learned so much from it. Suppose that you had the opportunity to launch a PrEP campaign for Latina. And I'm wondering, would you make Marianismo something that's among the primary components of your appeal to women? And if so, does this study, do you feel it tells you anything about, what you would focus on in that respect?
Yeah, this is such a great question. And so I didn't get to, talk about sort of the heterogeneity within Latina young adult women across different ethnicities, but there are really notable differences in terms of endorsement of Marianismo beliefs, especially because Marianismo as a concept sort of emerges from Catholicism and, sort of exemplifying the Virgin Mary. That's what a lot of these qualities are rooted in. So these cultural factors have been found to be salient for Latina women, whether or not they may be religious, sort of as a part of gendered socialization. But there are really broad ranges as to whether women endorse these sort of traditional roles or not, especially, as sort of time goes on and across generations within families. So I think any intervention that, especially a PrEP one that seeks to sort of account for Marianismo and gendered, values and beliefs and behaviors, I think would really need to be rooted in sort of a community context that assesses the particular area that the campaign is taking place and whether these beliefs are salient or not and culturally responsive or not. Because at least for the pilot study that we're conducting right now, a lot of the Puerto Rican and Dominican participants in the study have actually talked about how Marianismo was maybe more relevant for their parents' generation, but isn't something that they adhered to or endorsed. And certainly they were sort of familiar with the archetypes of the different belief pillars, but it wasn't, at least from our study board and members who have been participating in our, group meetings, they've sort of shared that these are influences that maybe they felt growing up, but that as adults, they don't feel are as relevant. So I think it's really fascinating to explore. And I think, any kind of intervention in this area should sort of be informed by focus groups and, engagement with the community where they can play a role in sort of deciding how and whether it should be incorporated. But I think whether or not we endorse these traditional gender role beliefs, we're all sort of socialized in kind of a patriarchal kind of context that makes us aware of how these may be impacting us in some level. But certainly tailored prevention efforts would have to really be engaged in the community and ensuring that these were something that would be helpful to include in an intervention like that and sort of account for. Long answer to that question, but thank you.
Great. Thank you, Melissa. Thanks for a great presentation. Thank you and everyone for a very interesting and thoughtful discussion. So now we're going to move on to our second presenter for the day, and that's Dr. Justin Knox, who is an assistant professor of clinical implementation science and intervention in psychiatry and socio-medical sciences at Columbia University. His research program is focused on HIV, substance use, social network analysis, and mixed methods research, primarily among vulnerable and marginalized populations, including racial, ethnic, and sexual gender minorities in both domestic and global settings. Justin earned his PhD in epidemiology from Columbia University, where he also completed his postdoctoral fellowship in substance use epidemiology training program. Justin also has a Master's of Public Health and Socio-Medical Sciences from Columbia, a Master's of Science in Medical Anthropology from University College London, and a BA from Middlebury College. Justin also served as a Peace Corps volunteer in Swaziland, now Eswatini. Over to you, Justin.
Thank you, Bob. Let me share my slides here. Great. Can everybody see those, hopefully?
Yes, looks good.
All right, great. Let me just move everyone's face here. All right, yeah, thank you very much for giving me this opportunity to speak today. My talk is titled Integrating Implementation Science into Observational Studies, an example from behavioral HIV research. This is a talk based on a paper that we recently had published in the Annals of Epidemiology. The paper is titled Proposing the Observational Implementation Hybrid Approach, Designing Observational Research for Rapid Translation. Here's the full citation information as well as a QR code. It's coming out in a special issue of Annals, but it's currently available online ahead of print, and it's been indexed in PubMed. As you can see, I had a great team of mentors and colleagues that I worked with on the paper. Definitely want to give my thanks and acknowledgements to them, as well as some other folks like Sandro Galea and Alfredo Moravia and Sharon Schwartz, who I acknowledge in the paper and who helped us formulate these ideas and get it written up and disseminated. So yeah, for some of my talk today, I'm going to spend the first half going through the paper, lay out the premise for why we felt this approach could be useful and why we're proposing it. I'll then summarize the three general contexts where we think there could be opportunities to apply the approach. Next, I'll describe some of the methodological considerations. And then I'm going to break from the paper a bit and get into some of the details of how we're currently applying the approach in an ongoing observational cohort study among Black sexual minority men and transgender women that we're conducting in Chicago. And then I'm going to end by talking through what we think are some of the implications, or at least some of the potential implications that we've thought of, as well as some future directions for this research. So just for context, I've realized many people come to this at different ways, but I think in the field of HIV and in public health more generally, right, there's increasing interest in a line of study called implementation science. I think the idea is that we've invested quite a lot in the development of prevention, screening, and treatment tools. We've invested a lot in conducting trials to evaluate whether they're effective and creating an evidence base for these tools. However, we've not invested as much in what leads to these tools being taken up and incorporated into everyday practice, right? So then implementation science is the study of methods and strategies that facilitate the uptake of evidence-based strategies to improve public health or clinical practice into everyday practice. And I've been getting trained in implementation science as part of the K01 award that I've been on for the past 3 years. And to give you a perspective where I came to this from, as Bob mentioned, my doctoral training is in epidemiology. And I started to wonder why epidemiologists are not really exposed to implementation science as part of their training, which is not to say that epidemiologists do not do implementation science work. Many do, right? And I want to acknowledge that epidemiologists have made important contributions to implementation thus far. Just in discussion with colleagues and mentors, I realized that there are many epidemiologists who are not aware of the relevance of implementation science to their work, as well as other researchers in general, right? And one thing I noticed is that a lot of epidemiologists, the way they're trained, are focused on causal inference, and they don't conduct clinical trials or do intervention work, right? And that's because many of the exposures that we're interested in as researchers, especially if we're focused on the social determinants of health, many of these exposures don't lend themselves to evaluation through experimental design, right? They're logistically difficult to randomize, or there might be limited resources or political will in order to do that, right? And so in these contexts, observational studies play a key role in figuring out what to do, right? They drive hypothesis generation. They identify modifiable conditions and targets for interventions, right? However, many epidemiologists conducting this work don't see implementation science as relevant to that work they're doing. And even other methods like the widely embraced effectiveness implementation hybrid approach, I think is seen as the work of interventionists. So the motivation for our paper is to say, actually, we think that you can start thinking about implementation science in the context of conducting observational research. And our paper is basically making the case that we should incorporate implementation science methods and measures into observational studies in order to collect information that would allow researchers to anticipate, estimate, or infer about the effects of interventions and implementation strategies. And we acknowledge that some implementation relevant concepts align well with what researchers already focus on, right? For example, how and under what conditions an exposure or a treatment work, while others we imagine will be less familiar, such as individuals' motivations and preferences for the uptake of evidence-based practices, or using methods that are less familiar, like qualitative methods, if you're trained to do quantitative research. Nevertheless, in this context of conducting a study to understand the prevalence of an exposure or whether an exposure causes an outcome, we feel it could also be useful to collect information around what could be done in order to address that exposure or outcome, or mediator or moderator, depending on the study design and the questions at hand. So that's the premise. And we acknowledge right up front that our paper, this proposal, is motivated by the effectiveness implementation hybrid study approach, right? Which is a widely used approach that argues that we should blend design questions of clinical effectiveness research and implementation research, right? Basically how and under what circumstances interventions can work in practice, right? Not just whether or not they do work. And that idea was put forward by Jeff Coran et al. Over 10 years ago. There was actually just a reflection piece on it that came out this December. And Jeff is a co-author on our paper, right? And he was implemental in helping think through this idea, right? And as I mentioned, this is widely embraced. We summarized some of those numbers in an earlier draft of the paper, but it's been cited over 2,500 times at this point. I just served on PPAH study section in March, and I'd say, over 2/3 of the trials proposed we're using an effectiveness implementation hybrid approach, right? So this idea, right, is basically if you're going to invest all of the resources to conduct a clinical effectiveness trial, right, which typically focus on whether individuals randomized to an intervention or treatment have better outcomes than the individuals randomized to a control condition. So why not use that opportunity to collect data on implementation, right? So you would find out not just whether or not something works, but what would it take to get it taken up and used in everyday practice, right? And it would be more efficient to conduct these hybrid studies, and it could shorten this off-cited 17-year gap from discovery to implementation of health interventions. So then in our paper, we argue that those conducting observational research are also well positioned to help close this gap from discovery to implementation, and specifically using an observational implementation hybrid approach could help decrease the time between observations of determinants of health and using that knowledge to actually improve health in everyday practice. So how could this be accomplished, right? So much, as I noticed, much epidemiological research, right, especially social epi research, focuses on these social determinants of health. And many of these exposures don't lend themselves to evaluation through experimental design, right? So in these contexts, observational studies are really what need to be conducted in order to generate hypotheses and identify modifiable conditions, right? And in many cases with exposures, right, there's often key steps along the causal pathway that allow an exposure or intervention to ultimately influence a health outcome, right? And the application of causal inference methods to observational data can address questions that experimental designs may be unable to address, right? And can provide results that are often more generalizable by enhancing the real world nature of the data collection, right? And additionally, when evidence-based practices exist, observational data can also be used to increase understanding of their implementation in a less biased setting, right? So observational data can also characterize the need for new or optimized implementation strategies to promote adoption of evidence-based practices, as well as monitor the transportability of effects across contexts, right? So there's a lot of utility for observational research. It's critical, and that's whether you view it as a separate pathway from experimental research, like in the figure on the left here, or as a precursor to experimental research, like in the figure on the right. And we believe that we could further increase the impact of observational study designs by broadening them to include the collection of data that could explicitly inform the design, implementation, or evaluation of implementation strategies on implementation outcomes. So we're basically proposing that researchers should think broadly about their research in the context of the research pipeline, about whether implementation science data could be collected as part of that observational research. And we note that this could have important implications for helping observational research more directly inform implementation, which I think everybody would agree is the end goal of the research agenda, right? Is to actually improve public health. So the observational implementation hybrid approach is relevant in 3 broad contextual scenarios: observational cohorts, programmatic data, and cohorts with study-linked interventions. And we provide examples of these in a table in the paper, and I'm just going to describe them briefly, right? So first, we feel it could be applied among observational cohorts that individually enroll participants and collect a natural history of their experiences or behaviors, right? These studies might include existing studies to which additional information to inform implementation could be added, sort of retrofitting them to use this approach, or new studies where a hybrid approach could be planned a priori, right? So measures could be added to survey assessments to understand the acceptability or appropriateness of relevant evidence-based practice to the constructs being studied, which I'll note exist independent of the results of these studies, right? So for example, whether I know how prevalent heavy drinking is, or whether it's causally associated with suboptimal PrEP adherence, independent of that, I know that there are a number of evidence-based practices to screen and treat alcohol misuse, right? Which I'll get into an example of this later in our applied approach, but we could begin to collect data on those aspects of implementation in the context of studying how common they are and whether or not they matter to the outcomes being studied. A second context where we felt the observational implementation hybrid approach could be used is when data is routinely collected as part of surveillance or program data. For example, studies using quasi-experimental designs that use routine program data, those could be designed to collect additional data to assess implementation science constructs, right? It can be done using quantitative or qualitative methods, and by including activities such as collecting data on relevant implementation science constructs, completing facility level checklists, linking participant data to clinic data or to facility data, as well as collecting costing data in the context of doing the surveillance work, right? Even program evaluation studies could be particularly well suited to answer questions associated with policy or guideline changes, right? Especially if the implementation of a program is occurring on a large scale. And then the third context that we envision is collecting data from participants in observational cohort studies who are also, in many, for example, HIV-related study, potential participants undergoing initial HIV STI testing to assess eligibility for study inclusion, right? And those eligibility screening tests include services like counsel, referral to HIV STI prevention or care services, right? And implementation relevant details of eligibility screening are typically not captured in observational studies, but additional data collection about those experiences and processes could be used to understand participants' experiences with those interventions. And by not collecting that, we're missing out on an important opportunity. Even unobserved interventions, such as presenting at a research site, right? Imagine one that's welcoming to racial, ethnic minorities or sexual gender minorities, right? That also warrants additional consideration. So data about research participant experiences in the research site would allow a better understanding of what characteristics of service locations might be more conducive to effective service provision. And finally, data could also be collected about compensation for participants and the extent to which those funds help mitigate known barriers to accessing healthcare, right? For example, whether it's used with respect to support for food or shelter or transportation or general well-being. Oftentimes, data about these things aren't collected, and we feel that's a missed opportunity. So, in terms of methodological considerations, we acknowledge that using an observational implementation hybrid approach likely requires having knowledge about relevant interventions or policies that impact modifiable implementation constructs relevant to the research questions of the study. If researchers do not have this knowledge at the outset, they could use literature review or consultation with, relevant parties to get that knowledge. It might mean expanding research study teams to include that type of expertise that, with researchers that have experience developing interventions and implementing them, right? It probably also involves learning about implementation science theories and frameworks, right? And which ones could be relevant to the issues being studied. We also feel that observational studies are well suited to study factors related to the transportability of potential interventions and implementation strategies, right? Specifically, researchers can use observational studies to measure selection factors, right? Characteristics of persons and settings that have been shown to impact the reach and effectiveness of interventions and implementation strategies, right? So that knowledge could help researchers understand which interventions and implementation strategies might transport across settings, right? And at one part in the paper, we note how instead of just estimating the level of burden of disease in the population or the population attributable risk, which is right the proportion of the level of a health outcome in a population that's due to an exposure, right? We could also actually approximate a population addressable risk, right? So that would be the proportion of the level of a health outcome in a population that could actually be addressed by using the current evidence-based practices to intervene on an exposure. Then observational studies could also be used to measure participant willingness to engage in interventions, their perceived acceptability of interventions that they have experience with, as well as preferences for interventions and implementation strategies. And lastly, we note that observational studies could also be used to collect data on patient perspectives about interventions and implementation strategies as the ultimate end users of these activities. So I think I'm about 10 minutes. So an exciting aspect of this, approach is that we're not only proposing the method to integrate implementation science research into observational studies, but we're actually currently applying it in an ongoing cohort study. And I'm just going to describe that now. So the networks and neighborhood study is a cohort, an HIV status neutral cohort study of Black sexual minority men and transgender women. It's being conducted in Chicago, Illinois. We currently have about, there was a part 1 of N2 that took place during COVID. It was to look at the effects of networks and neighborhoods on HIV prevention related outcomes. And then now we have a part 2 that's status neutral, and that's focused on determining the causal effects of substance use as well as sleep health on HIV related outcomes, right? So we're going to measure these exposures, follow the participants for 2 years, and then look at how they're associated with HIV related outcomes, both related to prevention, care, and seroconversion. So we've noticed in N2, right, which this is supported by nationally representative data too, is that various forms of alcohol misuse are prevalent among the participants, right? In this case, Black sexual minority men have as high levels of past month binge drinking as any other racial, ethnic, and sexual minority group, right? And this data comes from the National Survey on Drug Use and Health. And that same data shows that Black sexual minority men have elevated levels of past year alcohol use disorder. And so alcohol, like other health issues, there are a range of evidence-based practices that can be used to address alcohol misuse. I conducted a systematic review on this that was published in Lancet Psychiatry. There's screening tools, there's pharmacotherapy options, there's talk therapy, there's support groups, there's e-health and m-health tools, and many of these go underutilized, right? As with all these health problems, there's a major treatment gap, right? So this is that same NISDU data that shows that less than 10% of people with an alcohol use disorder receive any type of treatment for it. And these levels are similar among Black sexual minority men. And in the context of our study, since we're focused on HIV-related outcomes, we also know that alcohol is associated with worse outcomes across the HIV care continuum, right? So this really matters in terms of the health issues that we're focused on. I think evidence is emerging about whether or not alcohol use is associated with suboptimal PrEP, adherence and persistence. But basically, we know that alcohol misuse is prevalent. We know that it's a health issue. So instead of just conducting this study in a way that we'll learn how prevalent it is and whether or not it's associated with HIV-related outcomes, we want to conduct this study in a way that coming out of it, we'll also have a better sense of what could actually be done to address alcohol misuse. So in order to make the N2 study an observational implementation hybrid study, and not just a traditional observational study, we're also using this opportunity to collect additional implementation science data. So for example, we have a pilot study funded by the Columbia CTSA, and that's to develop a discrete choice experiment, right? Which is a preference elicitation method that can be used in order to understand participants' preferences regarding the delivery of evidence-based alcohol interventions, right? So that discrete choices experiment has been developed. We're currently pulling participants from the N2 sample to do some cognitive interviewing to make sure that it's understood and interpretable, and then we'll integrate it into the next wave of data collection starting in November. And coming out of that wave, we'll not only know how prevalent alcohol misuse is, but we'll understand participants' preferences for how they would like to receive interventions or be screened regarding their alcohol use. We also have another pilot study funded through the HIV Center to do some human-centered design work among a subsample of 30 N2 participants, as well as 15 HIV prevention and care providers linked to the study site, right? So we're using a journey mapping technique to understand Black sexual minorities men's experiences as they access HIV prevention and care services in order to identify opportunities where they could be screened for alcohol use, as well as offered evidence-based alcohol interventions, right? So for that, we're conducting in-depth interviews with, it's HIV status neutral, 15 positive men, 15 men who are HIV negative, as well as prevention and care providers to understand their physical and emotional journeys as they access these services, so that we could understand, what would be barriers to implementation of these services, what could increase their acceptability and uptake. So that's just an example of how we're applying the approach. I think of sort of why we think the approach is needed, how it could be used, and then an example of how we're applying it. And so I just wanted to end by talking about what we feel are some of the implications of the approach, right? And I think the end goal is to say, let's increase the impact of public health, increase the public health impact of observational research by making the findings more actionable, right? Coming away with knowledge, not just about whether or not certain exposures matter or how common they are, but what we can actually do about it. We feel there's important opportunities to increase crosstalk between people conducting observational research, as well as implementation science researchers. We also feel like there's important implications for groups experiencing longstanding inequities, such as Black sexual minority and transgender women, right? Where there's an imperative not just to continue studying these populations and understand the nuance of, say, how structural racism creates inequities, but what can we actually do about it, right? So we acknowledge that we still need to learn what are the issues at hand and what to do, but doing it in a way so that research is more actionable. And that, we didn't do a great job of this in the paper, but we imagine there are limitations about this, right? I think there's more work to be done to think through in what context would this approach make sense? And maybe there's context where it wouldn't, right? Where maybe there's very little known about the potential harms of an exposure, or there isn't much of an evidence-based, a pool of evidence-based, tools to screen or treat these issues, right? So that needs to be thought through some more. And then, finally, future directions for this work. So we're in the process of trying to disseminate this idea. I, recorded a podcast on it for Annals of Epidemiology, presented a poster on it at HPTN. There's a bunch of upcoming conferences where we'll be presenting on it. We think it's exciting, has some implications. I'm excited to get the opportunity to talk with you all about it today, and hopefully we have time for questions and discussion. And we're also, we're submitting grants, future grants, saying that we're going to use this approach and conduct observational research in a way that makes it more actionable. We hope that resonates with reviewers, and I think is a way to acknowledge that we still need to use observational designs to study what the issues are at hand, but also in a way that we can know what to do about the issues that we find matter. And then there's some follow-up papers that we want to write about this, each which needs its own type of framing, but we want to provide more guidance on actually how to do this, maybe call to, elaborate some more on some of the examples that we used in this paper, sort of breaking down how they're using the approach and what they've learned from it. We also want to provide some examples of it. I've talked with the editor-in-chief at HHPH about potential interest in that. And also, we think it has implications for training, right? For how I was trained as an epidemiologist, but potentially how other disciplines were trained. I was thinking a little bit about this with Melissa's talk, for example, right? Like, it was really interesting findings, but it's like, what do we actually do about it? And could that study have been conducted in a way that you have, information that directly speaks to that? And then, another, I think, paper calling out the equity issue and how that's really critical here. So let me stop there, and hopefully there are questions.
Thank you, Justin. Really nice job, and I think really important. And I guess I feel like, helping to transform the field in terms of, I think the challenge that we've all seen in research over many, many years is that it really does, I would say, take too long for determinant studies, observational studies to move into intervention and actually making a difference in the lives of people. So I appreciate that. I have a question that not very answerable, but maybe for all of us to think about. But I'm wondering if since you're enmeshed in this and with your colleagues about this methodology, do you see any challenges in NIH particular funding structure to be able to accomplish some of what you and your colleagues are proposing in terms of, like a study trying to do too much or being limited in terms of what it's able to focus on, and if it's observational or if it's a determinant study, why are you doing X, Y, and Z? And I mean, and also are the limits of the budgets of grants. But any thoughts about potential systemic challenges to do what's being proposed in terms of our funding mechanisms?
Yeah, no, I have a lot of thoughts on that. I'm trying to limit it to 3. One that I think is probably really relevant to you, right, is I was presenting a poster on this at HPTN, and I went to your HPTN 096 meeting, right? And they were talking through the study design and the changes that have been made to it, and there's all these secondary qualitative aims around implementation, right? No one was saying it was an effectiveness implementation hybrid approach, right? Like that I didn't see that language being used. And then I was speaking with some people afterwards that are involved with HPTN 096 that came to the poster, and they were saying like, yeah, like, NIAID dates, like they haven't drank the Kool-Aid with this hybrid, implementation science stuff. In my mind, it was like, oh, everyone's proposing this. I was on study section, as I mentioned, like almost all the proposals seemed like they were, acknowledging that we need to collect implementation science data in the context of doing trials, right? Because Like, we don't just want to know whether it works. We want to understand how to get it actually used in practice, if not a, purely implementation science research. So it spoke to the fact that, like, yeah, there are barriers. Not everyone believes in implementation science or, finds it approachable or understandable. There's a lot of theories and frameworks that can be hard to digest. And also people are like, what are we really getting out of this? A bunch of qualitative work around facilitators and barriers. Like, how does that achieve scientific consensus and actually move the field forward in terms of, what we actually do? So, and then the other funding point, there was my mentor, the senior author on the paper, Elvin Gang, wrote a piece in Science saying that we need to fund more implementation science, right? We need to invest more heavily in this. And then we wrote a response into that letter saying, like, we agree, but we also need to be more efficient. We need to use these hybrid approaches so that, when NIH does invest in studies, that we, begin to learn about implementation. And we noted that, like, the COVID vaccine efficacy trials, right, shown to be highly effective. But, then when it went to roll them out, a lot of challenges around uptake, right? And could we have been better prepared for that if we'd made a more concerted effort to understand implementation and understand what would be barriers to get people to be vaccinated? And then the funding issue you mentioned is real, right? I think the budgets of R01 studies, right, I don't think they've increased in the past 20 years, right? So you have to do more with less. And here we are saying, like, your team also now needs to include implementation practitioners and people with experience. I think there's also a movement to include community members and have more community engagement when we do research. But all that costs money and involves resources, but we're not increasing the budgets of these studies. So how do you do that, right? And that's in the context of R1, like R21s and R34 is even more limited. So I think it's a huge issue that you bring up.
Okay, very, very thoughtful response. Thank you. Tanya tells me that both Claude and Teo have their hands raised. So Claude, go to you first.
Am I unmuted?
Yes.
Okay, great. Justin, thank you so much. And both you and Melissa, it's going to sound so maternal, so I'm sorry, but do us, really proud. Like, it's really amazing to have you both. And I didn't raise my hand with Melissa, so I'm throwing that out. But to you specifically, I mean, you did a really nice job of describing this in ways I think that many of us can understand. And you just touched on something it would be great if you could speak a little bit more to. I think the problem with implementation science for many of us is it is really complicated. There are really complicated models when you're trying to explain it also to the people who are impacted. So the providers in clinics, the patients in clinics, it's even more complicated. And so to what extent does your work or this work involve stakeholders, both patients, community members, including providers, to actually try to translate some of this into ways that I think many of us could get our head around in a grant? I agree with you completely. As Bob said, we need to speed up this process. But I also think we have a disconnect between the language we use and what people can weigh in on to push the science and clinical impact. Did that make sense, what I just said?
Yeah, totally. I think there's a couple of issues right there. Like how can we make implementation science more digestible, right? Because it is confusing. There's like a million models and theories and frameworks. And actually, Jeff, I think has a nice paper, like really simplifying what it's about, but maybe it's overly simple. I think he acknowledges that, but then right, not that we need to dumb everything down to make it useful, but like this paper, I think, is speaking to those not engaged in implementation science, saying, you could consider its relevance to what you're doing because we think it would ultimately align with what you want to do, which is impact health, through actionable findings. But we feel like there also needs to be a paper to implementation scientists saying, like, if you want to get some of these people on board, you need to simplify your message and make it clear why it's important, make it clear what people are getting by incorporating this into their research and how it can be done, right? And that's the follow-up work we want to do. and then the community engagement piece, which is critical, right? And I do think one real contribution, at least my take on it about implementation science, is let's not just engage the users, but let's engage the providers too, right? So linking these data sets and these sources, and you asked how we're trying to do it. So for that, discrete choice experiment and sort of developing it and refining it, we both engaged with, technical experts to understand, like, how could we think about assessing preferences in the context of what could actually be delivered in clinical settings, and important to get their perspectives on that. And now we're going through this process of doing the cognitive interviewing and understanding how Black sexual minority men and trans women actually interpret these, questions and how they understand alcohol interventions and treatment options. And then for the human-centered design work I mentioned, there's both, we're collecting perspectives both from the, from the participant user perspective, but also from the provider, and thinking through, like, what is their journey providing care, and what are moments where they feel like they could ask about alcohol use, so that's just in our study. But I agree, it needs to be done, and done in more, better ways.
Thank you.
Okay, thank you. We have, I'm going to, before going to Teo, we have a question in the Q&A that I'm going to read, and then Teo, and then also I'm told that Christina Rodriguez-Hart also has their hand raised, so that will be after Teo. So Gordon Edwards has written in the Q&A, great presentation. What roles and opportunities do you see? This is related to, I think, the question Claude just asked. What roles and opportunities do you see for community-based organizations already using evidence-based interventions and engaging the populations we want to reach, become more regularly and equitably involved in implementation science research, especially in this hybrid model? In my experience, CBOs lack the resources and funding to do this research evaluation and increase the number of new interventions for these populations.
Yeah, I think those are all fair points, right? I mean, as long as, right, the current funding system, right, where, there's a call, researchers like scramble to it, try to get community on board, kind of, try to work within their systems and approval processes, but it's, challenging. And then, we're like, our careers, our system is based around like waiting for the funding decisions and having multiple proposals under review. And I just don't see how that possibly works with community. The surprising thing in my experience is that a lot of communities are actually still interested in research, even given all these barriers and this sort of crazy system that we have in place. So, I mean, it's a little above my pay grade to think how to fix it, but for certainly, and I think one of the initiatives of the EHE supplements, right, are that, a streamlined review process, trying to make it more community driven and engaged, seem like good, but like, it's still that crazy tight timeline, and, presented and proposed in a way that is more, conducive to researchers and not community driven. So I agree, there needs to be more work done there. And it needs to be more thought even with this approach, right? It's pretty theoretical at this point. It's in an academic journal, right? And I've been presenting it in academic context. Like, how could we, is this approach, could it be used to, present it to community groups and help them think through, like, okay, if we agree this is a priority, like, how could we make this more understandable and actually use this approach to, make it more community engaging? I think that's a certainly area of future research that needs more thought and consideration, but I don't have the answers for you.
Good questions and good thoughtful responses. Many challenges. We're close to running out of time. I'm going to let and Teo has given me permission to let Christina, if you can go first. Christina Rodriguez-Hart, I'm glad you're here. We're going to go to you next.
Hi, Justin. Can you hear me?
Yeah, to see you, to hear you.
It's great that you presented on this. I've thought a lot about effectiveness, implementation, studies, and approaches, in part because I focus on stigma research. And what we found in New York City is that a lot of times organizations feel that they're doing a lot of things that are effective towards reducing stigma, but they have no evidence of it. They haven't actually studied it and seen the impact on the outcomes on stigma. So we've thought about effectiveness implementation approaches as a sort of answer to the simultaneous problem of the fact that they're doing things that don't have testing to show that they're effective. So can we build the evidence base while also, implementing things and studying implementation and its rollout? But, I think at the bottom of one of your slides, you said as a form of a limitation that like maybe one shouldn't do this when you're less certain of its impact. Maybe that's what you were saying, but I think we really have to lean into the fact that a lot of times we don't know if things are really effective in an observational context, right? Like maybe an aspect of the services that we're delivering was shown to be efficacious and then effective in a trial somewhere else in some other population. And then now we're using it in our population with no idea if it really works in our own population, or maybe we've packaged it with 5 other components and now it's really a whole new beast that hasn't been tested, but we're delivering it anyways. So I'm thinking about, us health departments and how we fund a lot of services out there. We collect the data in an observational manner, but yeah, we're not looking at implementation studies. We're not doing those. We don't necessarily have the bandwidth to do that or the funding to do it. So I think we have to figure out like, how do we build this approach you're talking about into an observational context where studies are really not happening? Like no special studies are happening. We're just collecting data on a routine basis on our clients, and where is the room in there to get this implementation science focus in there as well. I think in particular, as relevant to stigma research, we could think about the opportunities for this for existing quality improvement and quality management programs. So the State Department of Health does a lot of clinical quality improvement, and they're funded to do so. The New York City Department of Health for the Ryan White Part A program has a quality management program that's funded, but they're not doing implementation science. And so how can we integrate the stuff that you're talking about into the already existing processes at play by people who may be not familiar with implementation science or don't know how to use it? So
thank you, Chris. I'm sorry, I'm jumping in, Christina. Thank you. We're actually just past the hour. Justin, I'm going to please take a minute for a very brief response. Christina, it's always very thoughtful, and I'm glad you shared all that with this audience. Justin, real quick, and then we're going to have to wrap up.
Yeah, no, I'm going to reach out to you, Christine, because I think that's like a huge question. I know, like, actually in epi, right, there's a big movement, this target trial emulation data, stuff that Miguel Hernan is pushing, saying like we need to use observational data to emulate trials. It's actually, more generalizable and even, shows, similarly useful in evaluating effectiveness. And how can we expand that to also include assessment of implementation? So that's definitely something we're thinking about. As I always no clear answers yet, but I think an area that needs more thought, and I'd be happy to work with you on thinking through that, because I think you're right. It applies very much to the great work you guys are doing.
Great. Thank you, Justin. Thank you, Melissa, again. Really, obviously stimulating, and we could obviously be going on longer and longer. And thank you to our audience for being here. See you next on June 22nd for Steve Safran round.